Good afternoon, everybody, and welcome to this webinar. I have a pleasure to have my panel with me today, Klaus and Martin. We decided before this that we are friends and colleagues. So I'm starting first, and then I'll be followed by Martin, and then Klaus will continue after that. At the end, we have, that's me, we have a questions and answer section, and we encourage you to ask questions, and we'll do our best to answer them at the end. Okay, so that's our topic today, running group clinics remotely, IT and governance challenges. So the objectives we're going to cover today, I will talk a little bit about long-term condition issues, and then our Queen Elizabeth Hospital group clinics experience. I'll say a few words about Attend Anywhere platform, which in fairness I haven't used before, and it's not our official platform at the QE. And then Martin will talk about his experiences in terms of remote patient care, virtual consultation and MDTs, and he'll tell us a little bit more about information governance issues. And then finally, Klaus, who will essentially talk about his experience about group clinics. Then hopefully we'll have time for a short discussion at the end. I'm not sure whether you're aware, but NHS is actually planning to start virtual group clinics. And I suppose that's reasonably imminent. So starting with me, so just in a view of background, so we have in England, and that's 2015 data, over 15 million people who are living with one or more long-term conditions. And obviously they're costly, and a single long-term condition costs about £1,000 and goes to £3,000 and £8,000 respectively for 2 and 3 conditions. So the number of people with 3 or more long-term conditions is rising. We had around 2 million in 2008, and we have in 2018, I believe. I think the screen is, yeah. 2018, we have around 3 million. So obviously a huge chunk of GP appointments, up to 50%, and hospital appointments up to 65%. Are all for people with long-term conditions. And if you look at the costs, enormous, 70% of total health and care spend goes for caring for people with long-term conditions in England. And obviously they're on the rise because we're getting older as a population. Now, if you look back at the costs, so this is a fairly recent publication from European Commission, 2019, and this is how much we spend in euros per capita per patient. So, and overall, if you look at the number, 1/3 or 31%, to be more precise, is spent on outpatient care. So it's a huge amount of money, both in the UK and in the EU. Now, obviously, we can deliver specialist-led care in groups, and group clinics can include patient clinic management, obviously education and support. And the question is whether this is a way to replace at least some of individual patient consultation. Now, is this a way to modernize service and make it more efficient? That's something which certainly we can discuss at the end. I think according to the data, we have 90 million outpatient episodes every year in the UK, and the numbers are steadily increasing. Can we actually cope with that in the future? No, so this is our experience, and it's fair to say that we haven't established a remote video group clinics as yet. We have individual video clinics, but not group clinics. But I think this can work as a good platform, and this is an example of our DMT discussion group clinics, which are run by our excellent MS specialist nurses. Birmingham, in Birmingham, we have obviously a large area of inner city for first-line DMTs, and then we are a regional center covering 4.5 million population for second-line therapies. Initially, they've been running for the past 10 years or so, and initially they developed due to very large waiting lists and also capacity issues with clinics. And then I think our team philosophy is to educate our patients, which will hopefully then help that they adhere to treatment. Now we had before COVID pandemic around 6 to 7 groups, clinics each month. They were separate for first and second line treatments. Up to 6 patients per each group, lasting up to 2 hours. And obviously, some individuals were not invited because of the obvious issues like cognition, anxiety, language barrier, etc. So every patient will receive written information in the information letter, invitation letter, and they are encouraged to attend with somebody, a relative or friend or partner, and they will be supplied with a DMT booklet directed to MS decisions. And then some screening tests will be done as listed here, and I'm not going to go into details of that. And then what is covered, obviously we cover mode of action, side effects, monitoring, initiation issues, all the technical issues about the delivery, training, and administration. Look at their medication lists, look at their relapse rate and steroids treatments once again. We talk extensively about pregnancy, foreign travel, vaccination, any supplementary therapies, and more importantly, at the end, about stopping criteria. They're generally educated about the lifestyle, work, issues with children and pregnancies, diets, how to manage side effects, and the importance of adherence. Overall, the feedback was always very positive, and we audit our discussion group practice every 12 to 24 months, and these are the feedbacks we received from patients so far. So now, how are we going to do that in the future? I don't know. Currently, we are using something which is called Video Connect, but I believe that the Attend Anywhere platform is going to be used widely in the NHS. I'd like to hear from Martin and Klaus whether they got any experience with this platform, and also from our attendees, any personal experience about this. And this is obviously a busy slide, lots of information about it, so I'm obviously not going to go into details of that, but there's a good comprehensive information about it on their website and also on the NHS websites, and obviously further information you can find down below here. And then the final, one of my final slides, I believe, is what's happening with group clinics, generally speaking, in the UK. And this is something I found, publication from NHS Wales, rather fresh, from 3rd of December. And there are serious plans there to introduce group clinics in Wales. So, and obviously the numbers here. So 11,000 GP consultations, 62,000 secondary and community care appointments have already been taking place virtually in Wales, which is obviously a big number. I'm not sure whether we have any data for England. And obviously they have big plans to introduce that in various specialties, diabetes, musculoskeletal conditions, rheumatology, dermatology. Neurology is not listed at the moment, but I'm sure it's coming. So this is probably all I have to say at the moment. So I would like to hand over to Martin.
Thanks very much. So Martin Wilson, so I'm a neurologist, like Gordon and Klaus by background, and MS is my subspecialty, but also have some management and leadership roles. I'm a clinical director for the service here, and digital lead at the Trust, but also for Cheshire and Mersey, and also have a specialty advisor role to NHS England about commissioning and pathway development. So I'm sort of coming at it from several different points of view, I guess. So what I'd like to cover in a fairly short presentation today is obviously a bit about virtual consultations, including MDT. So my experience of that, particularly in MS Clinics and some other MDTs here. And I'll talk a bit about Attendonera and the other platforms. Some of the challenges that brings up about remote working. So how do you do outcome measures? What's the role of wearables and apps? Always a lot of interest in that. Patient portals. Touch on digital exclusion or inclusion, whichever way you want to look at that. Obviously, that's an important issue. These platforms aren't going to be suitable for everyone. Some of the lessons related to this from COVID specifically. And I'll touch on some of the regional and national context about the governance and also the commissioning and funding of some of these things and how that affects how we will work. So just as a bit of context and background, I think, important to note a lot of this predates COVID. COVID has emphasized and accelerated a lot of this, but these next couple of slides are from a report from the RCP, which was pre-COVID. And so firstly, from the clinician perspective, if you look at the traditional outpatient model, we know a lot of appointments are unnecessary or they happen at the wrong time for the patient. A lot of clinics finish late. There's alternative options, but we don't use them. And some of the data, a significant proportion of appointments seem to be unnecessary. And that, when you ask people that actually, when they look at those, they could easily have been done in a non-traditional way. And if you look at that from the patient experience, I think we forget how time-consuming and difficult a traditional outpatient appointment is. The time off work or family commitments, it's a 10 or 15-minute appointment to us or a half-hour appointment, but it's probably half a day at least for the patient. The report showed that 1 in 5 of elderly patients actually felt worse after their appointments just because of the stress of the journey and the appointment itself. And it's interesting to note that if you look at all the traffic in England, a significant amount of that is NHS related. So this is all in the Outpatients, the Future report by the Royal College, which is quite a nice report. Actually, I recommend reading that. So a big part of that, of course, and what's been accelerated by COVID is virtual consults. So a couple of things just to think about what we mean by that. Do we mean synchronous or asynchronous? So virtual care can be asynchronous, so you're not with the patient. So email messaging systems or other digital messaging systems through a digital platform are a sort of obvious example of that, where you send, patient sends a message and you reply with some care advice at some point, the equivalent of just writing a letter. Also think about what platform you're talking about in a very crude sense, because the first question is video or telephone, and I think we get a little bit obsessed with video calls because they're the new funky sexy thing, but I think we need to focus on using those where they add value. So there's a number of consultations where telephone call, which is a very robust technology, is just as good. So think about where you need it, and obviously think about the limitations. You can't examine your patient at all on the telephone. You can in a limited way with video call. you can't take blood, you can't do an ECG. You need to think about other ways of doing that. I wanted to mention time and efficiency. So again, there's a sometimes misconception that these are an answer to capacity issues. Yeah, they're really not. So these appointments are no quicker than a face-to-face appointment for the clinician and for the hospital. So the traditional model is actually very efficient in that way, because you've got your expensive resource, your clinician in one place, and the patient's sort of a wheeled or trooped across them in a sense. So that's actually quite an efficient model in that limited sense. So what it doesn't get you that, but it does give you different ways of accessing patients in different ways and at different times. That mean you can change your model of delivery, so it's overall more efficient. And access, I've put, so access, I mean access for the patient to a video platform or telephone, which will vary obviously according to various factors, which we'll touch on in digital exclusion, and access for the clinician. So you might be in a room where you're not set up for video calls. Yeah, not every PC will have a camera and a microphone that's working. So always have a plan B. So the plan B is usually the telephone, essentially, and I think I'll come on to the attend anywhere experience, but we still have a significant proportion of consultations that are planned to be video, but end up being a telephone call for reason either the platform's not functioning properly, or the patient can't get on it, or you can't get in it. One or the other. So that happens a fair amount. So you need to have a plan B. So thought it's also worth just talking with virtual MDTs. You think about what we mean, because that actually covers different things. So we're talking about MDT meetings, MDT clinics, and then patient group meetings. So that's the terminology I would use. So by an MDT meeting, I'm talking about maybe a radiology MDT or a neuro-oncology MDT. So just a group of clinicians without patients there, having a meeting in a virtual way. And that obviously, again, has been very much driven by COVID, but actually has been that's been very successful in my view. So the platform we use for that, for example, is Teams. So we don't use that for our clinical sessions. We use Attend Anywhere. But Teams is very good for MDT meetings. It's obviously a video platform, but it's also a collaboration platform. So you can keep documents there, you can edit them, work on them collaboratively. So you can have a list of your patients that you're seeing in the radiology meeting and so on. You can log the outcomes more easily. So it actually facilitates a better way of working for some of these meetings. So our radiology MDT actually has been improved by doing it virtually. And it also opens up other possibilities. So it means you can invite people from outside your organization that you couldn't do before. So if you've got radiologists elsewhere that want an opinion or so on. So it actually expands some of your possibilities. And then in terms of MDT clinics, so we're obviously focusing on MS here, which is an obvious example. So our experience of that is basically a mix of platforms, which can get a bit, it is a bit of work involved for the clinical staff. So we're using Attend Anywhere as the video platform for the patients, and we can invite other people. You can invite other people, other specialists in either at the same time, or you can message them to call the patient in later. So the patient goes back into the virtual waiting room after I've seen them, for example. I message the other members of the MDT. So we use Teams for that. So we have a group and a channel within Teams for the MS MDT. So all the clinicians are on there, the therapists are on there, the MS nurses, the orthoptists. So we message each other on there and say, can you call this patient later? Or can you, this patient's back in the virtual waiting room, can you call them in? So you can have a functioning MDT, but it's not entirely straightforward to set up and manage. It's there's effort involved. You've got your EPR open, you've got Attend Anywhere open, you've got Microsoft Teams, you're keeping your eye on emails as well, possibly. So it's it's a bit of work, but that's an MDT clinic. And then of course you can use it for some of the educational meetings for patient groups as well. So there's another slightly different use. So we use it for our fatigue management course, a newly diagnosed course, and so on. So again, we use Microsoft Teams for that, and not Attend Anywhere, though you could use that. The other thing I think from a practical point of view to think about here is particularly going forward when we're coming out of COVID, how much of this do we keep and how much do we leave? How do you organise your face-to-face appointments and your virtual appointments? Do you keep separate weeks open for those? Or do you have blended clinics where you just do a clinic, and then within that list of people, there's some that are going to be a video call, some that are going to be telephone, and some that are going to be face-to-face. There's different challenges depending which way you do that, but it's definitely an issue that we need to address, particularly as we come out of COVID and more. We're not going to have to do them all virtually. We're going to do the ones virtually where it makes sense to do it. So one of the things we need to think about, obviously, is outcome measures. I don't want to spend too much time on this in interest of time, but obviously think about what we're doing in normal clinics. So in terms of MS, doing an EDSS, documenting relapse rates, compliance with DMT, safety monitoring. How do you do those things if you're doing a virtual clinic? The one thing I would say is just don't try and necessarily just replicate what you currently do. You use your digital tools to work in different ways and collect that information, for example, using a patient portal, which we'll touch on, or a wearable if that's going to work. So these do offer ways of doing that, but some of the existing standards, so the EDSS, I suppose, is a good example. There's already established ways of doing an estimated EDSS by a telephone assessment, so you can certainly do it on a video call. That's been published quite a few years ago, and you can argue that's not as good as doing it face to face, but I would argue that in a lot of clinics, you're not doing the EDSS absolutely robustly as you would in a clinical trial anyway. You're essentially doing an estimated EDSS, and you can do that perfectly well in a virtual clinic. Very quickly mention wearables and apps. Obviously, there's loads of these. I put up just a few examples there, and again, always generate a lot of interest. They sound funky, they sound interesting. Their role is so far been very limited, and the reasons for that is that they're all different. They all work in slightly different ways. The information that they collect is generally siloed, so it's restricted to the device that the patient has. So you're then left with, how do they get it to the healthcare professional? They email it to you, God forbid, or they bring it with them at the time of the clinic, which is really no different to just bringing, a diary or something. So that doesn't really shift things, I don't think, in a dramatic way. So I think if these are really going to change things, and certainly if you look at activity trackers and paces and speed of walking, some of these are perhaps genuinely useful things, but we've got to integrate them with either your own EPR or a national database to make them actually useful. Patient portals are, I think, an important aspect of this. So if you want to run things virtually, and if you want to facilitate other aspects of modernising outpatient care, such as flexible follow-ups, open follow-up, what we call PIFU, patient-initiated follow-up, portals could be a really useful way to connect the patient to the provider. But again, there's lots of challenges. So there's lots of different ones, lots of different platforms, they work in different ways, and you end up with this very difficult position again, where they're not integrated with your own system. So how do you access the data in an easy way? I think ideally, what we should aim for is procuring these things on a regional basis, at least, maybe even national. So ideally, I think you'd want the NHS app to be the front door to these things, even if the underlying platform might be a different one, but the front door for the patient is always the same. Because if you think about it again from a patient perspective, what they don't want to have to do is access lots of different apps depending on if they're attending this hospital or that hospital or their GP. We really need to think about how we commission those, what the footprint is, regional or national even, and how you make the front door easy for the patient. For example, use the NHS app, and then how you get the information out of that and surface it to the healthcare professional in their EPR or their local system. So it's not all that straightforward, but potentially you could use these for a lot of things. So obviously, you can remind patients about their appointments. You can send them questionnaires and surveys, so you can start to get some patient-related outcome measures and feedback. Monitor things like, mobility and steps, relapse rates, putting in blood test results, so there's a lot of potential there for collecting data as long as you can actually get access to it. I'll put a few examples there. I say that there are multiple ones in use throughout the country. But digital exclusion is a real issue. So, we say everyone's got a smartphone, but not everyone has got a smartphone or knows how to use it. So we reckon this was 2019 data, I think. So about 20%, 1 in 5, don't have those sort of digital skills. Risk factors for that are probably unsurprising. So the elderly, but people with disabilities, lower income and non-English speakers. But if you're looking at long-term conditions like MS, look at this. People with disability, 35% less likely to have those skills, even by 2030, we're looking at probably 10%. So a significant minority. Although it's a minority, it's significant enough that whatever we do, we need to have pathways to deal with those issues. That includes getting better access, skills and confidence, and that includes staff, and designing our digital solutions in a sensible way, which has not happened a great deal. So in terms of COVID, I mean, some of these I think are obvious, but what has COVID done? It made us very rapidly focus on what's actually essential care and what can be deferred, although deferring has caused some of its own problems. There were some temporary information governance easings, which I'll mention in a separate slide, which was essentially, as long as it's in the interest of patient care, just do it. And that went beyond information governance to just general bureaucracy as well, I think, which in some ways was actually quite refreshing and interesting, and it showed us what we could do quickly in terms of completely transplanting services from one hospital to another within a period of days, the sort of stuff that would take in years before. But I think it's also taught us that you can't do everything remotely. We just don't have the tools to do that, and probably won't. So you can't do it all. So you can't just switch everything to virtual. But it has made us examine some of our long-term practices that we probably should have been looking at anyway. So if you look at long-term conditions like MS, the traditional model, as I said before, was already broken. Just seeing someone every 6 months or 12 months that just suited us. That's why that's why that was in place. We needed to change that anyway. And it also made us look at funding. So a lot of funding and commissioning was sort of put on, on pause. And again, it was a very much just do what you need to do attitude. But that means you've got to refresh and look at how you fund some of these things. So as an obvious example to that, there's never been adequate reimbursement or funding for virtual consults, so telephone or video consults until this last year. So, hospitals have been very much paid to see people in a face-to-face appointment, and that's how they get paid. So that's what they do. So unless you change that, they won't do that. And there's no incentive for hospitals to do flexible follow-up and just see people when they need to be seen, which would suit the patient to be right. But of course, then the hospital's not getting reimbursed. That money is sitting in other pots. So we need to change that. So that brings us on to the national context. So as I said, the traditional model is that hospitals are paid basically to do stuff. So therefore they do stuff. They will see people in clinics. The temporary situation is moved from tariffs. So we've had this system called payment by results that a lot of you will have heard of, which is really a complete misnomer. It's nothing to do with results. It's to do with activity. So it's payment by activity. So shifting from that to block contracts partly helps, but it's got its own problems. And I'm not going to bore people with big discussions about commissioning and funding, but the move is toward blended tariffs, which is a kind of a mix of the two. You get a chunk and then you get more for certain activity or complexity. And the problem, I think I've already mentioned really the problems. The problems with the current system, there's a big disincentive to do things in a different way, to see people flexibly, to do virtual consults, because there's just no funding model for it at the moment. this is a very busy slide. I don't expect you to read this, but so this brings us on to the sort of NHS England work, which I've had some involvement in. So some of you will be well aware of this, of what was called the Optimum care pathway. So it's been done in partnership with the NHSE, with the National Neuro Advisory Group, the ABN, and various clinical leads. Alistair Cole's been involved in this particular pathway, among others. So this is about developing model pathways, which are not really the topic of today, but there's a significant focus in these on technology, which I think is just worth emphasizing. So one of the key recommendations was to take advantage of local and national technology in clinical management. And that included a few things. So clinical management tools, so digital tools to sort of standardize management, getting a minimum data set into a national register, data sharing, use of patient portals, so you can share clinic letters but have and blood results, but have two-way communication as well. Local IT systems for blood to be sent to specialists. That doesn't mean that. I think that I don't want any blood to be sent to me, but I think we all know what they mean. This is a massive problem, isn't it, in terms of disease-modifying therapy monitoring. So how do you get sight of blood tests and results that have been done elsewhere? And some regions have that solved, but lots of them don't. And overall, of course, this model, the aim of this model is to have a sort of a regional sort of view where you've got specialist care, maybe in a tertiary centre, but that is networked so that you've got an equitable way of accessing patient care anywhere in that region, and all that is linked digitally. We're not just siloed, working separately. I'll have to speak about the information governance, because that's the topic of today in particular. And I'll just mention a couple of things. So one is you might have a COPI, or COPI, which is Control of Patient Information Regulation. So these are not something we usually hear about, but Secretary of State has powers within Section 3, which relates to communicable diseases, which is why it was enacted this year. And essentially the COPI rules, or the COPI regs, essentially allow organisations to share what would normally be viewed as confidential information much more freely in the interest of public health. So it's mostly about data for sort of planning and service planning in terms of beds and being overwhelmed and all that sort of thing. But it's also applied to just more freedom to use certain digital tools during the pandemic that normally would have been considered not quite secure enough to use that way. So WhatsApp, Skype, and so on. Which I'll come back to them. I think it's just worth mentioning about the issue about information sharing between organisations for the issues. Now, I think this is also always worth going over, because there's a lot of I think confusion and anxiety about this. But if you're sharing information for direct care, so clinical care, not research or audit, that already exists. So the permission to do that already exists in the under existing GDPR, GMC, Codicart, ICO guidance, and you don't require explicit consent for the patient to do that. You don't. That was actually already in place, but again, quite emphasised during the pandemic. But you still have to exchange that information in a secure way. So that brings us to the digital platforms, the virtual platforms. So the use of things like Microsoft Teams, FaceTime, WhatsApp are currently all covered under the COPI regs, if you like, the COVID regulations. But it is a little bit of a grey area what will happen when we're out of that. Some of these platforms, so Attend Anywhere, one of the issues of it, I'll speak a little bit about my experience with Attend Anywhere. So we use that a lot. It's a video platform. There are lots of video platforms. The advantages of it are that it's on the NHS procurement framework. It is approved as being secure. I don't think it's super reliable. And one of the difficulties, unless we've used lots of the different platforms, it's very hard to know which of these are better. It's obviously been rolled out on a national procurement, so it's been free for trusts to use. So that's obviously why it's been very widely rolled out. apart from those trusts which already had something procured. And that's being extended certainly for certainly in our region for the next 12 months. That's going to differ from region to region. But then there's probably going to be longer term procurement projects after that. So I think we'll be able to get a chance to compare some different products, which I think will be important. But security-wise, it's one of the few. There's a handful of others that are on the procurement frameworks that have passed the relevant security checks. And Microsoft Teams, I think, is definitely here to stay as well, and is probably considered secure. Again, some slight grey areas there actually, but so it'll be interesting to see how that plays out in the longer term. And I think that is all I have to say before handing over back to Gordon and Klaus. So thanks very much.
Thank you, Martin. Thank you, Klaus, for joining us, and thank you, Martin, for your very interesting talk. And hopefully that will encourage a few questions at the end. And now over to Klaus.
Thanks, everybody. And I think this is really kind of a little bit of an extra that I can potentially contribute here, because I'm less embedded in the really the NHS frameworks and that Martin and Gordon have been talking about to an extent as well, of course. But I think it's fair to say that it's more sort of the research that's been driving my interest in a group clinic, and this is what I have to say. And this is very much a joint venture with Andreas Stennett, who is an academic physiotherapist, been working with me on that. And so this was about an off-license treatment option for people with advanced MS. And many of you know that we're running a trial that hopefully will start recruiting from April, which is this one. And this is actually really the start of a presentation that I would give to a group of patients in that disease state. So people usually in wheelchairs, often with partners or their carers coming along. And we would invite them for essentially a 1.5 hour, 2 hour session in an afternoon. And as you will see towards the end, I think this would lend itself almost ideally for a remote situation, and therefore I think it has translation potential also for current research. So many of you may have seen the overall concept of Chariot MS. I'll show this to patients, although they're not coming for the trial, but I show them what kind of essentially the backdrop idea has been or was for to set this up, and just showing them where that's hopefully all going to happen. And but then I tell them that they're actually not being enrolled in a trial. Okay, I think this is always very important to make clear then. And we've been offering cladribine as a compassionate treatment because we think it's safe and well tolerated. And we have obviously not the definitive evidence to say that it'll make them better at the disease stage they are. But we're obviously hopeful, and that's why we've done all the writing and the research and also the campaigning around this. This took several years to get to the current state. Also explain that they're not on their own, because it's about 40% of patients that are affected by this degree of disability, and but that we obviously need to think of upper limb function as an outcome, because that's you have the leveling out effect or very steady effect at EDSS 6.5 around 7. And there's probably more variation still in the upper limb function. And some of you may have seen this cardboard version of the nano-peg test. We do send them home to patients now as well, I mean, quite regularly as part of our remote assessment. And so that works reasonably well. We explain what the 25-foot walking test is, if that still applies, obviously, because We're talking here people with EDSS 6.5. And also that they can do the web EDSS. I think that's already been mentioned, which correlates reasonably well with hands-on delivered EDSS. And I mean, let's face it, who in clinic actually does a full-blown EDSS? Because it takes the time. I mean, you can't avoid taking 20 minutes, 25 minutes to actually fill in the form and do it all. So I think it's fair to say in most cases, it's a bit of a rule of thumb EDSS anyway. I also make clear that they have to have very realistic expectations, so that we are hopeful to delay worsening or stabilization ideally, and no more. We're going through the adverse risk of the treatment, all of that. And as you can see now, all of this could be done just as well from a remote perspective, instead of dragging them all into the London, where they have no parking and difficulties accessing the whole service. We'll also go over lumbar punctures, because that's part of the assessment prior to being eligible for the treatment. They have to have an elevated neurofilament light chain level, at least now that we've moved on with the overall program. Explain that we're using atraumatic needles, reducing the risk of post-LP headache syndrome. Also tell them that it's a bit cheaper to do that, but that's obviously a side issue. They can obviously get more information or prepare themselves through a little microsite or HTML5 that Alison from our team had produced to explain what the lumbar puncture is actually for, and also to, in a way, enhance a little bit the capacity for people to ask for an atraumatic needle. So I don't know whether people on the panel or the attendees disagree with that. It would be quite interesting to hear. We also made the information accessible publicly, so the information and consent sheets, everything is kind of available on SlideShare. And here's some of the feedback we received. So this is we did sort of evaluation forms, and here people, I mean, felt it overall very useful, but it was a length of time. Okay, so I would have liked to have been told about the possible length of time of today's appointment. So I had to rely on other to look after our children, etc. So long distance, and maybe people are here on the call that send patients in for assessment or for treatment. So thanks very much. But evidently they came from quite afar sometimes, and it's quite a hike to do that. It also expressed, I think, in the next evaluation form, where essentially all that is left here, we're all quite happy overall, but it's just difficult to get to London and the distance to attend and the cost. So it's essentially asking really for a remote solution, certainly combined with some of the elements that Martin and Gordon described, also including remote assessments and potentially some whatever you can do through a video screen in terms of examination, which is a bit of a difficult term. So what are the challenges here? I think the challenges probably would be less in the IT sector, because I appreciate there is a limitation of people that can join a call. I've been very much using Accurex in my practice, which I find neat. It's also an NHS digital approved system. It's very robust, and it's dead easy to use, to set up and use. But it's got 4 slots maximum, so I don't know whether that can be extended. And I think here, to be honest, the more challenging element was more the whole debate around off-label treatment and how much sort of outside the box you can actually put yourself to promote the idea, obviously with the backdrop of eventually getting a trial underway that will make it hopefully possible to roll this out on a wider scale. So these are essentially my questions, if there are any needed for the discussion. Do they improve quality fundamentally? And I've come up here with respect to outcome measures, because as explained with the EDSS, if we do it poorly, then it's probably no better than a very thoroughly done web EDSS. I was also thinking about social capital, which is probably more valid in a group setting face-to-face, but it may also work online, as it were. Do they save time, as in money? I don't know about that, because it still takes time commitment for each individual. I should say, when I was talking about the research driven setting, that I also did see these patients then face to face afterwards, but I think it would be fair and square to now think about something that a concept where that runs entirely remotely. And then, yes, the question, does it help achieve higher goals, as in, getting a trial underway? And I think that is also a question you can discuss. So I've left 10 minutes, Gordon, for the discussion.
Thank you, Klaus.
Yes.
Obviously, it's a different angle because you're talking about your research practice, but I think it's an important one because we're all struggling with the capacity, and if we could do at least some of our research assessments online and perhaps in group kind of sessions, I think there is obvious benefit there. And I'm not sure what you think about it, Martin, but I can see the appeal of that. So I think it's certainly very interesting.
I think it's an interesting question, isn't it, about the distance for patients. So that's been a limiting factor in the past, hasn't it? That if you've not got a multi-centre study, then if it's just been run out of London or Sheffield, then you're basically going to be restricted to patients that live in London or Sheffield. I mean, does this, I suppose, if it potentially does open it up to more people, doesn't it? But you've still got the challenges of once you recruit them, they would have to have a significant amount of their monitoring and so on done locally, wouldn't they? But it does open up some possibilities to need less infrastructure and approval and ethic and local ethics and all the rest of it locally, if you could just coordinate it and do it virtually from one centre. Yes,
I mean that is already happening, I think, and I think people only just really realize, I mean, what the potential for that is, because that can be a driver, as you say, for equity and access to studies, right? So sitting somewhere, I don't know, in the countryside doesn't mean anymore that you're less able to participate in studies, at least in a, I think, an increasingly proportion of them. I think that's definitely a good thing. There was another question here about charging, which I think is very sensible. All right, Gordon, you even said, well,
no, I think it was just a bit interesting.
Yes.
So whether, I mean, I don't have an answer to that. I know that we're charging as a telephone, for a telephone consultation, there is a charge. And there is a way of doing it. I'm not sure how it works in London and in Liverpool. I think, whether you have any comments on that?
Yeah, well, I mean, in our practice, it has to be set up as a clinic, as a remote clinic. And I think the major challenge there is usually to get this set up. I mean, it can take a very long time, I'm sure. I'm singing from the same hymn sheet as many, that these things could just take very long to eventually set up. And I mean, to be honest, I myself and I probably shouldn't say that, but it's really not so much on my mind when I'm thinking about this. I always think about what's the best for the patients, and they but the problem is, with a specific clinic code comes a certain set of, letters, information flow, expectation, how you sign it off, and so on afterwards. That makes it then, just more cumbersome, and that in the whole context can slow it down.
Yeah. So the whole issue of how you resource things like advice and guidance, as well as remote consults, whether it's telephone or video, has never really been properly addressed. So so some areas have negotiated local tariffs, for telephone consults or for virtual consults. But I think this is going to be so there's nothing to stop you doing that, but you can't get away from it as an issue, unfortunately. If you really want to shift a lot of your activity to virtual or to advice and guidance, which there's very good reasons to do that in terms of overall patient care and the overall health economy. Because this is the problem. I think the answer to your question, Klaus, that you raised is, is it more efficient? Does it save money? It does if you look at the global economy and for the patient, the time and money and travel, all those. But for the hospital, it's an absolute disaster. So it's not going to happen unless we change that. But I think there is an acknowledgement nationally that is a real issue, and that the future commissioning and blended tariffs and all this sort of thing are, you're essentially going to have a pot of money for a population that is defined, and of course how you define that is going to be slightly nefarious, but there'll be a pot of money, and then if you look after that population, that's fine. It's up to you then as a service how you do that. You don't have to see them face to face in the clinic. So there are then incentives to do things in better ways.
Yes. There's another question. I don't know, did you see it, Gordon?
So if you can maybe comment on that, I think obviously doing lots of research, Klaus, is this something you could answer? So what is the best self-monitoring tool for, especially for the EDSS monitoring? Is there one you would recommend?
Yeah, well, we've started using what we call 3 tests, but it's essentially the MSFC and replacing the PSAT with the SDMT. I think it's quite commonly sort of done now in research, certainly, but we've managed to get this underway in earnest over the last 3 years, really, to start initially on an annual basis, but we're obviously hopeful to get a little bit more granularity in the future. Now with a remote setup, so that we get that. These tests have the benefit of being very easy to apply. You don't even need a healthcare professional to do them. You can teach them quite easily. They're quantitative. They're not, a scale like EDSS. It doesn't need so much intervention. And we also use the able hand questionnaire for upper limb function. So obviously, it's a bit our emphasis on progressive or advanced disease. But I think these are quite useful tools. The SDMT is a very sensitive measure to measure change. I think one has to be a little bit cautious with the 4 points that Ralph Benedict suggested as the kind of clinically meaningful change, and act upon that immediately. But I think it's clearly sensitive. We've looked at a cohort which just actually submitted the paper, and what comes out is essentially that is really where the change is detectable within a year.
I think so just coming in on that, I think because the focus of the question was that how do you get patients to use them, and I think that's going to be
engagement.
The problem, isn't it? Because there are good tools, but I think if you look at it from a patient perspective, it's a good question. So why am I doing this? You're going to get some very highly motivated patients, of course, who want to do it and love to do it. But if you want to do it at scale, that is a challenge, isn't it? About how what's the benefit for them? Motivate people to do it.
Yeah.
Can I just ask you? I think we're running out of time slowly. which platform I think we should be using in the future? What's your prediction? What do you think? Can we say that now, or shall we try them all and then decide which one is the best? And also, shall we wait for the Wales to give us preliminary results in terms of their kind of experience in terms of group clinics, and then we all kind of follow their example and avoid their mistakes? So what do you think about that?
I think it's very difficult because Attend Anywhere, so we'll have a lot of information. So Attend Anywhere has been used in most, well, not most, but a large number of trusts over the last year. But obviously it was kind of rushed and people were trying to implement it very quickly. It's not usually been embedded into local EPRs, so that will obviously work much better if it's actually part of your appointment system rather than a separate siloed platform. So I think there are, I've not been amazed by Attend Anywhere, but I think in some ways you might say that it's been an unfair judgment. But on the other hand, it's been used in Scotland for years, so it should be a very polished product. But we don't have lots of comparative data. I think I'd be quite interested in seeing how if Microsoft can get Teams. So there's a clinical module functionality to Teams which has been developed. I think that's definitely worth looking at. We're going to be using Teams anyway. That's here to stay. So I think that's one platform we should definitely look at more. And then, as I say, there's a handful of others. AcuRx has been mentioned. That's that's been used a lot in primary care, whereas Attend Anyway has been used in secondary care.
Yes.
So it's a very
all the time,
yeah, that's right. Yeah, and I think it's very difficult to know which is the best without some good comparative data. It's a bit like comparing different DMTs, isn't it? Without a head-to-head.
Okay, there are a couple of quick questions, if we can answer them. So any advice about moderating between participating chats?
Yeah, that's right. I picked that up, and I thought this is one of the great benefits of group clinics. I would actually encourage the chatter between them and sort of between patients. And that's what I said. I think one of the advantages of a group clinic is indeed that kind of peer-to-peer support, and call it social capital. That can emerge from that. So I think that is rather something that I think is beneficial than negative.
Yeah, I agree.
Okay, that's good. Okay, and shall we? Do we have any more questions? Actually, there's one more question here. Local digital hubs for those patients who don't have access to technology. I'm not aware of any in Birmingham area. So I guess there is access to technology in Birmingham, but there are remote places, Herefordshire, for example, which we cover. So I wouldn't know answer that question.
I think it varies very much from place to place, but I think it's a good point, and I think any region that's looking at their offering needs to you look at the GP surgeries, the libraries, the community centres. Where there's going to be access for these sorts of services. Absolutely.
Thank you all for helping and participating. And I guess we'll probably meet in the future. There will be follow-up of this because we will need to change our practices. It's not because of the COVID only. I think we need to modernize and change. And I think remote video consultations, they will stay, and I suspect we will use remote group consultations more in the future. But I think obviously there are challenges in between, organizational and technical, understanding which is the best platform. I think that's something which we don't know. So hopefully we'll be in a good place in 12, 24 months' time, and we'll be able to work more efficiently and have a combined service with face-to-face assessments, and then video clinics and remote group clinics. So that's probably all I have to say. So Klaus and Martin, thank you. And hopefully we'll meet again in the future.
Thank you.
Thank you.